I also have a side interest in bone health. And I'm here today and together with Dr. Aziz Faruqi to discuss with you the management of bone health issue for breast cancer patients specifically. So I would like to welcome everyone to today's session, including our spokesite participants, the ACS Health Team staff partners, and the ACS and ACC Hub team. So this clinic, basically, this lecture, and more than a lecture, we want it to be kind of an open discussion forum. So it's an opportunity for everyone to engage in an interactive learning experience with cases that you can discuss and ask questions upon. And so this ECHO model was actually designed to be an all teach and all learn experience. So we would like today's session to help extend your knowledge, skills, and ability to provide better care around bone health for breast and prostate cancer patients in your community. Today specifically, we're focusing on breast cancer patients. So going to the next slide, we are looking at the agendas for today's program. Basically, we're welcoming and opening announcements. Then we're going to go around and do a little bit of introduction. Then there's going to be a patient case and a didactic presentation by Dr. Aziz Faruqi. And then there's going to be ample time for Q&A and patient case group discussion. And finally, we're going to underline some key takeaways from today's meeting. And then we will have our closing announcements. So if we can go to next slide. So just a little bit of housekeeping. Use video whenever possible if you can sign up just by phone, but there's actually data showing that at this Zoom time, people feel more engaged if they're actually facing faces rather than just black boxes. Mm-hmm. And if you can face the camera when you're talking, that also would be helpful. So if you can enter also your name, title, role, and institution where you're from in the chat box for attendance tracking. And then I'm going to briefly call on you and just to introduce yourself so that we can engage as if we were in a room rather than just a virtual meeting. You can press *6 to mute your phones when you're not speaking to reduce background noise, and then press *6 to unmute if you want to comment or ask questions during Q&A. And also you can enter comments and questions in the chat box during presentation, and we'll go back to it or we'll stop and address your question. Another option that you have is to use the raise hand feature during discussion if you want. I guess everybody's pretty familiar with Zoom by now. And also, last but not least, today's session is going to be recorded. So I'm going to briefly call on people. So if you can just state your name and where you're from and what's your profession. So I'm going to start with Leah Mitchum.
Hi, good afternoon. My name is Leah Mitchum. I am employed by the American Cancer Society. I'm based in Southwest Florida, and I'm part of our cancer control team. Thank you.
Thank you so much, Leah. And then Chitkar.
You're muted, I think, Ritika. That's my PA, Ritika from Sloan Kettering.
Okay, that's fine. Yeah. I'm going to skip. So Georgette Valls Delgado.
Good afternoon. I'm also with the American Cancer Society, and I primarily manage the relationships with our hospital system partners in South Florida.
Perfect. John Falcone.
Hi, Dr. Fornier.
Hi.
John's an endocrine fellow at Sloan Kettering.
Okay, Dr. Faruqi did the introduction. Hi.
I worked with Dr. Fornier when I was a resident.
Okay, that's fine. Maureen McGuinn.
Hi there, I'm Maureen McGuinn with the American Cancer Society based in Jacksonville, Florida.
Okay, perfect. Megan Ailawadi, I hope I'm saying the name correct.
Hi, this is Meghna Lawadi. I'm in internal medicine geriatrics. I work in Mayo Clinic and I primarily do cancer survivorship. Nice to meet everybody.
Thank you, fantastic. We need a lot of physician addressing the survivorship issues. MD Dawkins.
I'm Monique Dawkins with the Association of Community Cancer Centers.
Okay, thank you. Tiffany Fountain. You need to unmute yourself if you want to speak. Tiffany Fountain.
Yeah, sorry about that. I was double muted. Yes, Tiffany Fountain. I'm also with the American Cancer Society, and I actually work up in the Wilmington, North Carolina area.
Okay, perfect. Thank you. And Zia Wang.
Hi, this is Xia Wang. I work for Moffitt Cancer Center. I'm a geneticist. I take care of lots of patients with BRCA1, BRCA2 mutation carrier who had, breast cancer and, lost their ovaries and all that. I'm very happy to join today to learn.
Okay, thank you so much. I think that was everybody. Maybe someone will join later on. So next slide. And I'm going to leave the field to Dr. Aziz Farouki, and he's going to discuss management of bone health issues for breast cancer patients. Thank you so much.
Okay, well, thank you, Monica. Let me just pull up the slide here. Okay, can everybody see my slides?
Yes, I can.
Okay, actually, good, okay. So yeah, we're gonna talk about all things relevant to bone health and breast cancer today. We won't get into metastatic disease so much, but we can talk about that. We can talk about anything. This is a really free-flowing discussion. Let's see, now I wanna, yeah. So these are some scenarios that do come up in my clinical practice. That you could think about bone health and order a DEXA scan. So a premenopausal patient on tamoxifen is one scenario. Iatrogenic menopause due to GnRH therapy, plus or minus tamoxifen or aromatase inhibitor, chemotherapy-induced menopause. You could also say oophorectomy causing surgical menopause definitely can induce a rapid bone loss. AI therapy. And you could also do a bone density on any postmenopausal patient who has risk factors, really. Now let's see. Okay. So we're going to start with a case, and this is a 66-year-old white female, low-risk hormone receptor positive breast cancer, and she has osteopenia. So this is her description here, and she's going to be started, not surprisingly, on aromatase inhibitor therapy. And so she has relatively mild osteopenia, and she doesn't have any risk factors for fracture. Her FRAX calculation is below the thresholds of 20% for any fracture and 3% for hip fracture. And now, we endocrinologists, when we see patients, we think about secondary causes of bone loss. And I think a lot of oncologists do too. I mean, most obvious is vitamin D deficiency. Other causes, hyperparathyroidism, hyperthyroidism due to maybe too much thyroid hormone. There's a whole list of them, that you can go down. But the relevant questions here are what is this patient's risk for bone loss? What is this patient's risk for fractures? And would you treat her with something to protect her? And for how long would you treat? So patient is actually is concerned, like a lot of patients out there, about adverse events, like adverse effects of drug therapy, like osteonecrosis of the jaw and atypical femur fracture. But she's also very interested in potential adjuvant benefits, because you, as a good healthcare provider, have brought this up, because there is data to this effect that's, I think, important for patients to make their risk-benefit decision. Okay. I'm trying to advance. Yeah, okay. This is a slide that shows us what happens when you start an aromatase inhibitor, and actually you get a sense of what happens when you start tamoxifen too. This is tamoxifen causes some gain in bone density, and versus if you start a aromatase inhibitor, like in the ATAC study, the slope of the bone density loss is greatest sort of in the first couple of years, I would say. And then it may slow down a bit. So this is in each of these studies, you kind of see that there's an initial kind of rapid bone loss that in the first couple of years, let's say, that may slow down to some extent after that. But I think the aromatase inhibition, causing the estrogen deprivation, the fracture risk, as long as they're on the drug, it's going to be there. It's going to continuously elevate the fracture risk, and when you stop it, we'll see what happens. Okay, next slide. And here we see that, again, in this big study, the ATAC study, that 5 years on an aromatase inhibitor versus tamoxifen, you can see that the AI group gained bone density, and the lost bone density, and the tamoxifen group gained bone density. And importantly, there was a difference in fractures. So you might say, well, this was an agent, the tamoxifen is a SERM, and in postmenopausal women, that has a bone protective effect, not in premenopausal women. It's a strange thing, but that's the way it is. And this is clearly harmful. So it doesn't tell us strictly compare AI compared to placebo, what is the fracture difference, but we will see that in another study we're going to look at. Okay. And here we see that after the aromatase inhibitor is stopped after 5 years, there is thankfully some recovery of bone density, both at the spine and the hip. And in the tamoxifen group, there is, when tamoxifen is stopped, there is some small loss of bone density because that you're taking away a bone protective agent. So then, when the drug was stopped, the fracture difference, we'll see this. You can click the forward and go ahead to the next one. And one more time. The difference in fractures here is apparent after the drug is stopped. The aromatase inhibitor is stopped at the 5-year mark, or the tamoxifen is stopped. There's no more, the groups merge in terms of the fracture incidence. So, that's good in that if the AI is going to be stopped, I think, anybody can chime in, but a lot of times we're continuing for 10 years, right, Monica? I mean, that seems to be a trend. And so, still.
Definitely, yes, because there's some data showing extended benefit beyond 5 years.
Mm-hmm. Thanks, Sarah. So, when it is stopped, I think we'll get our fracture risk will go back down. So that's a good thing. Okay, next slide. And here, the question is here, what therapy would be appropriate for this patient who's starting the aromatase inhibitor? And so we got all these good things here, ensuring proper calcium and vitamin D, nutrition. You don't want people losing weight, especially our geriatric patients can get into those syndromes. And my colleague on the call can talk to us about that later, who's a geriatric specialist. All these things are important. The non-pharmacologic, the pharmacologic therapy, I mean, the bulk of the data is with bisphosphonates and denosumab in these AI-treated patients. And the anabolics, really, there is no data using them in the context of the aromatase inhibitors. This is a new anabolic on the bottom, which is the monoclonal antibody to sclerostin called romosozumab. No data there, but I'll show you quickly a little bit of mouse data with these PTH analogs that stimulate bone formation. That probably, in my opinion, it wouldn't be a good thing to give somebody who's just starting in AI. So first of all, though, this study was quite a well-designed and landmark study. Now my life is complete now that we have this study, because this was a prospective, randomized, double-blind, placebo-controlled study, and it was done in Europe. Anybody know what country that is? We can all vote and get a prize at the end if we get it right. It's not Delaware or New Jersey, though. So anyway, but
it's Austria.
Well, we have a real European here, at least former European, so she got it right. Yep, thank you. So they randomized these patients who were just starting adjuvant aromatase inhibitors. These were non-metastatic patients, early stage, to denosumab 60 milligrams every 6 months or placebo. And they did this regardless of the initial bone density, which to us endocrinologists was really kind of shocking. That how can you do that? But nonetheless, it was done. And they looked at the primary endpoint of this study was actually time to first clinical fracture. So importantly, you know, the other studies weren't really, that wasn't the primary endpoint of that other big study, the ATAC study. It was all sort of just a adverse event reporting and so forth. So, okay, let's see what they found here. I can't advance the slide here. Let's see. There we go. Okay. And so what we found here was that the bone density, you know, obviously with denosumab, it's a very potent anti-resorptive, probably the most potent anti-resorptive we have, that they gain bone density over 3 years, both at the spine and the hip. Okay, so no shock here. We'll go to the next slide. And what we did find that was somewhat interesting and surprising was that if you look at the blue line, the placebo group really had a very high risk of fractures around the 5-year mark if you look at 60 months here. You know, that tells us that these patients do need to be protected, you know, however we want to do that. And, you know, the denosumab reduced the risk of fractures here, as you can see pretty clearly. And these were clinical fractures. When they did this analysis, there were 7 doses given over 38 months. Okay, but the study, you know, Monica can correct me, but I believe they were going to be treated for 5 years. Was the goal.
Yes, the study went on for 5 years, but the caveat is that patients could enroll in the study even if they had been previously on an AI for up to 2 years. So that's why some patients were on DMAP for the full 5 years. Other patients were on DMAP for, like, you know, different length of time, sometimes only 3 years. That's just because they could have started an AI already and that they could have been enrolled later. And yes, I agree with you, Aziz. Actually, there was a striking incidence of fractures, perhaps because we don't know maybe when patients are getting a fracture. Perhaps in this study, they, you know, within a clinical trial, they were followed more carefully. They did X-rays and so forth. And so sometimes our patients, they complain of back pain and joint pain, but they're older. Everybody has joint pain. Everybody has arthritic pain due to the aromatase inhibitor. And so I have a feeling that sometimes some of these fractures might go unnoticed in the clinic. And actually, and these were not due to metastatic breast cancer. There were only 16 cases in which it was the pathologic fractures. These were insufficiency fractures.
Yeah, good points, thanks. Okay, we go to the next slide.
Dr. Faruqi, I made you co-host. You should be able to advance them now yourself. But if not, I'll keep going.
Let's see. Why can't I do it? I don't know.
No worries. I got it.
Okay. So here we have showing us the fracture reduction. So first of all, the risk of fractures was similar if you had normal bone density or osteopenia or worse. And actually, even, you know, regardless of your age, which was somewhat surprising because we know that, you know, the older you are, the higher the risk of fractures is, and the lower the bone density, the higher the risk of fractures is. So, but we see here that, you know, the fracture risk was pretty similar here. And the reduction brought about to denosumab was pretty similar as well. The hazard ratio going around, you know, 0.5. Okay. Go to the next one, yeah. So, and the distribution of fractures, you know, these are all sort of typical osteoporotic fractures for the most part. But importantly, the adverse events in this study, there was no cases of atypical femur fracture and no ONJ. So that was definitely reassuring. And the one thing that is noteworthy here, though, is that these were all Austrian or Swedish patients. So, you know, in the US here, at least in New York, we have a multi-ethnic group we deal with. And the, that has to be taken into account. And that may have explained some of the findings, specific to this study, because if you look here, the fracture risk, if you take a U.S. Caucasian with osteopenia, and you see here that the fracture risk predicted by FRAX is very similar to that of the Austrian patient of Caucasian ancestry. But the other ethnicities have lower fracture risk, okay? So we pointed this out in a letter to the Lancet, and they accepted that. Okay, next slide. So bisphosphonates also, have been well studied in this context. We'll get into that. And, the regimen that's usually been used is zoledronic acid, 4 milligrams every 6 months. Oral bisphosphonates have been studied in the context of aromatase inhibitors too. And, they should, as we would expect, there's some data that they reduce fractures, bisphosphonates do. So again, I would be hesitant to use the PTH analogs like Forteo and Tymlos in this context, unless the patient was in remission for 10 years. And there is some, because these drugs, they increase bone turnover. And we'll get into this a bit more. I'll show you on the next slide here. So here you see that in this mouse study, at mice given PTH, they had to get prior auth from the mouse insurance company first, of course, had an increase in this in trap levels, which is an indicator of bone turnover, bone resorption. And not only that, they had more tumors in terms of the seeding of bone. So, this is not definitely applicable to humans. We just don't have enough data, but I think there's enough theoretical concern here that we wouldn't want to give a PTH analog in this context. Okay. And, interestingly, in 2019, there's been some convergence of data, I would say, that with bisphosphonates, you see that the mechanisms, the putative mechanisms here, where they could induce an adjuvant effect, were thought about over the years, and on the left over here. Then if we click one more time, Nicole. With denosumab, there's also data that emerged. Okay, one more time. And again. And to me, the common denominator here is the effect on the bone microenvironment, because you have two different classes of drugs in that the way they work is different. One is a monoclonal antibody, one is something that binds to bone, et cetera. And they both reduce bone turnover. And probably, to me, that's my thinking, is that the mechanism has to do with something related to the effect on the bone microenvironment. Okay, and here we see a slide that tells us that in the premenopausal state, with estrogen around, there is not much stimulation of these disseminated cancer cells that can happen. But if we think about, and in this context, okay, if we click, this is sort of a barren soil. And if we go to the postmenopausal state, you have osteoclastic bone resorption. And this has been talked about in the context of metastatic disease, where you have the bone matrix being turned over and the liberation of these matrix-derived growth factors here. So that could, stimulate the dormancy of these cells in the marrow and promote metastatic progression in bone. Okay. And here, this is sort of, you can think of it as a plow, and like the soil is being turned over. So that's the more fertile soil in the postmenopausal state, as opposed to the premenopausal state. Okay. And indeed, with denosumab in the ABC-SG18 study, there was an improvement in disease-free survival. It takes a little while to show up here, but all these patients, again, had recently initiated aromatase inhibitors. And you see that the median doses was 7, the interquartile range was 4 to 10. And you see the absolute difference here of about 3.1%, which was very similar to that shown with bisphosphonates, as we'll see. Okay. And this is important that this double benefit, this adjuvant benefit and the anti-fracture benefit, I think a lot of patients, I would want to know myself about this effect, will help them figure out about starting treatment. And it depends if that patient is a minimalist or a maximalist and so forth. Okay. Nothing is perfect. So with the denosumab data, there was another study, the DCARE study that we know about. A lot of us know about that. Was using sort of higher dosing frequency of denosumab, and it was a different patient population here. Most of these patients, only 4% of the patients in the DCARE study had no chemotherapy. 75% in the ABCSG 18 had no chemotherapy. It was, higher risk, et cetera. So there was no benefit found here in disease-free survival in this study, and there was more osteonecrosis of the jaw found in this study, not surprisingly, because they were using, more intensive dosing. Okay. Now, when we go back to bisphosphonate data, we think of this big meta-analysis that was published a while back. And in this study, they looked at all these, over the years, all these multiple bisphosphonate trials, and they pooled it. And you see here, they had tons of patients, and the treatment duration mean was 3.4 years, median follow-up 5.6 women years. Okay. And you click one more time, Nicole. So in this study, the premenopausal, there was no benefit in premenopausal women when in this meta-analysis, but in postmenopausal, of course, that's where the big benefit was. In the absolute benefit, again, this is a meta-analysis, but it was comparable to adjuvant chemotherapy here, okay? Postmenopausal in this analysis was defined as a natural menopause or induced by chemotherapy. Okay, next one. The benefit, the survival benefit here in this study was driven by less bone mortality, less bone recurrence is what it looks like. And you see here that over 5 years, numbers are different, and then over 10 years, that difference is maintained, basically. Okay. But there was no difference in non-breast cancer mortality because there has been a lot over the years questioning data suggesting that bisphosphonates could improve non-breast cancer mortality, overall mortality as well. But that is not borne out here. The bulk of the data, again, was with zoledronic acid, 4 milligrams every 6 months. And that's what we have in the US. We don't have ibandronate 50 milligrams daily. We don't have clodronate really, and neither did the others. Okay. Now, if you want to give this kind of dosing, there is an indication for endocrine therapy-induced bone loss. And when we order it, we check that off often either for zoledronic acid or denosumab. Now, we won't get into the metastatic bone disease dosing unless we want to later, but there is some data now that Zometa every 3 months and denosumab 120 every 3 months just from ASCO is non-inferior. Okay. So do you think a breast cancer patient with normal bone density needs anti-resorptive therapy? So I personally, I would take the ethnicity and the fracs into account. I would, talk to the patient and figure out, are they a minimalist or maximalist? Because as we all know, some people say, give me everything you got. And other people say, I don't want your drugs at any cost, like leave me alone. But I think it's important to give them some sense that there is some data out there. And then, I leave it to my oncology colleagues whether, their risk is such that they would benefit from more further risk reduction as well, I think. So again, the adjuvant benefit with bisphosphonates is regardless of hormone receptor status. That's been shown in that meta-analysis. We don't have that data with denosumab in HR negative, and indeed we have some conflicting data here, although the patient populations are different. What would we do with this patient? Risk for bone loss, what's the risk for bone loss, what's the risk for fracture? Okay. You can advance, I think, Nicole. Yeah. So the menopause, you know, and the aromatase inhibitor, well, if they're close to menopause, if they're within 5 years of menopause, that itself is going to induce a lot of bone loss. And this patient wasn't, she was 66, but the AI will certainly do that. And, you know, the FRAX calculator, I think, is going to underestimate this patient's fracture risk. And I think top choices are these two agents here. And how long would you treat for? You know, about 5 years. You know, and it's debatable, I think. But in our institution, you know, the 3 years has somehow gotten into the culture. But you know, I think you can certainly go beyond that if you want to. But for me, I would always chase the denosumab with a bisphosphonate, and I'll show you why on the next slide here. So, you know, bisphosphonates, they bind to the bone, they bind to bone mineral because of their structure, right? They're going to stick to bone after you've given them for a few years. So you don't have to worry about this loss of effect. But with denosumab, you know, there's a rapid loss of effect, and there's even cases of rebound spine fractures occurring. And we can advance one more. And we see here that, you know, with the bone resorption marker, CTX, it falls very nicely on therapy. And then it rises like crazy right when the drug is stopped. And while that is happening, you know, on the right side here, you can see that the bone density, you know, goes way up. And then when it's stopped, the bone density falls down precipitously. And again, you know, there are these cases out there of spine fractures happening in this period. And we looked at our institution and we found something 1 out of 300 and something patients that we analyzed, I believe, had this problem. But, you know, 1 is enough to make you never, you know, take this very seriously. Okay. My take-home points is aromatase inhibitors increase bone loss and fractures in the Austrian cohort, even at normal bone density. And then we should have a lower threshold for giving anti-resorptive therapy. And that in the US, you know, zoledronic and denosumab both have some data to support either use. But if the main goal is fracture prevention and not adjuvant, really you could use an oral bisphosphonate if you want. It's cheap, and you know, if the patient takes it correctly, it's effective. But the patient has to take it on an empty stomach and wait half an hour, et cetera. Just take it with tap water, et cetera. Okay. And you know, this was written up in this JCO article now 3 years ago. Okay. We created, Monica and I and a few other people at Memorial created this little algorithm here that kind of starts with the question, is there enough risk to justify incremental adjuvant therapy? So if there is not, then you know, you go down this side here and you ask, is there osteoporosis or a history of fracture of the spine or hip? Then you know, you could treat them with anything you want because that's clinical osteoporosis. If there's not, then you have to go down and figure out if there's osteopenia, if they're high, you know, and then you calculate the FRAX risk. If they're on an aromatase inhibitor, you know, you could treat them to just for the sake of preventing bone loss. But if we go to the right side here, if there is enough, you know, justification for adjuvant therapy, then you know, you can use zoledronic acid, probably foremost, because the data, you know, from the meta-analysis is quite strong, and that's if they're hormone negative or hormone receptor positive. So again, but there's no labeling for this type of use, really. Okay. Now, I want to just close with this comment here that, you know, in the osteoporosis world, after 5 years of bisphosphonate or really long-term denosumab, this can happen. And this is a stress reaction in the lateral femur that you're seeing here. It's a little blip on the lateral femur. And the patient would complain of an aching anterior thigh or groin pain, probably. And you can see this on multiple imaging modalities, okay? You know, this could be confused with metastatic bone disease, actually, too. But this is the precursor, and this could develop into a what's called an atypical femur fracture. So we all want to be aware of this, because with treating with these potent anti-resorptive drugs, there's a rare risk of this happening. I would go to the next slide. And, you know, we see here, though, in perspective, the risk of fracture untreated, then the risk of fracture treated cut down by about 50%. And then if we keep clicking here, yeah, you see that compared to the risk of fatal motor vehicle accident, murder, you know, the risk of ONJ and atypical femur fracture is really quite minuscule. There was just a New England Journal paper demonstrating that the amount of fractures you prevent is so much greater than those iatrogenic fractures that we're thinking about here that everybody's very, very afraid of. That's it. That's my last slide. I hope we can discuss some of these issues. Okay, we hit everybody with a lot of info there, so.
You know, before we get started, if you don't mind, if we could ask a few of our participants who joined to also introduce themselves, who didn't get to introduce themselves earlier. Dr. Fornier, can you hear me okay?
Yes, I can hear you fine. I think actually my nurse, Luisa Rotulo, joined. Hi, Luisa. You can unmute yourself and say hi. Then we have a Michael.
That's my fellow, I think.
Okay, I'm sorry.
Hi, yes, hi, it's Michael.
I'm sorry.
Hi, I'm the fellow at Sloan Kettering.
Yeah.
And then there's a 3F05 number, but I'm not sure.
No,
okay. Luisa is waving her hand. So it's okay. Okay.
So
now it's
Sorry,
open
guys.
for discussion. Anybody who has a question or?
Dr. Fornier, there were a few more I saw. Dr. Hollinger, did you get a chance to introduce yourself today?
But that's okay. I'm Julie Hollinger Johnson, one of the endocrinologists at Moffitt.
Okay.
And Sarah Logan?
Hi, I'm Sarah Logan. I'm one of the physician assistants in the endocrine department at Moffitt.
Thank you. And then Hall? Is Hall still there? No. Okay. All right. Over to you, Dr. Fornier. Sorry.
No, it's okay. I was just saying if anybody wants to start commenting or has a question.
Are you guys out there talking about this adjuvant data, or is it still too murky for you with the denosumab and so forth? With the patient, I mean, talking to the patient about it.
I think I always felt more comfortable talking about the data based on the bisphosphonate as adjuvant rather than the denosumab, but now I'll change. So.
Yeah, I mean, you know, but it is, I think it is a mixed bag, you know, that the two studies with the denosumab, you know, it may take several studies, I suppose, to really bear it out. I mean, it took, right, Monica, took a meta-analysis of 18,000 patients to really conclusively prove that. And
definitely. Well, and, you know, it's also upsetting in a way that we had two trials that with kind of conflicting data, although I have to say the difference between the two adjuvant DMAP trials were mostly patient population. They were really very, very different patient population. The Austrian study had mostly older postmenopausal women, hormone receptor positive breast cancer, mostly node negative. The vast majority had not received adjuvant chemotherapy, but hormonal therapy only, as opposed to the other study, which instead had a very, very much higher risk patient population. So, you know, it's a little bit like comparing apples and oranges. And so, but, you know, taken all together, we do have a fairly large amount of data showing that these agents, besides, of course, you know, improving bone density and reducing the risk of fractures, so can also improve breast cancer outcome. And the way really that usually as is very, very well explained in one of your last slides, the way that I discuss it with patient, but also with my colleague, is that you have to try to separate the two issues, the issue of the adjuvant benefit and the issue of the bone prevention. So if you have a patient with, say, very low risk breast cancer, older, not negative, very small size of disease, and you don't really think you're going to start her on an AI, and you don't really think that she's going to derive, that she needs, or she's going to derive any additional adjuvant benefits. So then the discussion is really going to be focused on her bone health. And vice versa, if instead you have a patient with higher risk disease, not positive, that you want to give her everything possible to diminish her chance of a recurrence, then it's more, it's heavier, the discussion upon the adjuvant benefit of the bone modifying agent.
Mm-hmm. Mm-hmm.
Do anybody find resistance? Do patients particularly resistant when you discuss these agents with them? What's your experience in general? I see a lot of heads nodding yes, right? Exactly. Yes, they're always saying that they that the ONJ or
Yeah. Yeah, I feel like the ONJs, please.
the atypical femur fractures. There is a bunch of issues that always come happen. I find patients are, for whatever reason, they accept a lot of therapies, but they are very resistant. And I think, osteoporosis is called a silent disease, and that's because people don't realize that they have it until when, they lose height or they get a fracture, insufficiency fracture, and then it's a little bit too late.
Yeah. I mean, I tell people about, in the osteoporosis world, it's a different story than when we used to give Zometa every month to people who have metastatic bone disease,
exactly.
The risk of ONJ, right? Because, I cite that in the big study with Reclass, once a year for 3 years. There was one case in the placebo of ONJ and one case in the drug group. And that I tell the patients, look, it's, it's not a zero risk, but it's very low based on that study, and both of those patients probably had risk factors and so forth, poor oral hygiene, diabetes.
I think I think sometimes, I remember early on in my training, one of my mentors said, you have to be a used car salesman sometimes, talking about how to get
all the time. I think this is going to be my next profession, actually. That's what we do, literally. We always have to convince people to.
What's in their own best interest?
I would have picked a different profession, I think, but I do think that there's a lot of truth to that, and our patients are so, the shared decision making that we all do, and all of the things that we have to go through as far as risks and benefits. And I think having that data and even visually seeing some of those graphs for our patients is helpful.
Yeah, no, definitely. I think, if you show them slides or something, definitely helps. No, but it's also, I was just at a meeting recently this past week, and somebody said that, nowadays with the internet and everything, everybody thinks they're an expert, all of a sudden, somebody who is a used car salesman, all of a sudden is a virologist, and he can discuss the COVID, Right. So lots of times you find people that, have very little expertise, but they feel because of all the mass of information that we're bombarded with that they can find. And yes, there's always some sort of resistance to start these drugs in general. Yeah.
Right.
I wanted to say too, sometimes when I'm doing my car dealership spiel with them and negotiating them to take the medicine, a lot of times they like the idea of taking Reclass because you don't need to use, a chaser like you do with Prolia. So they're like, well, if I'm going to end up on that anyway, just give me that.
Yeah, that's a fair point. I kind of tell patients, well, look, the Reclass, the zoledronic acid is less complicated, and then the reason is that you don't have to chase it. I think in our institution, it isn't being chased all the time still, and vast majority of the time it's okay, but it's not ideal. It's really there is that risk out there.
I think the one problem with the zoledronic acid is these are all elderly patients, and that can cause a compromise of the renal function. So you have to be careful about that. I think DMAT overall is easier to administer, but yes, you have to be careful. I have to say that, for example, during COVID, I ended up, either chasing patient with a dose of zoledronic acid or giving them alendronate by mouth so that they didn't have to come back, when they were falling, for example, I don't know, March, April, or something exactly at that date.
Yeah.
A question. So these studies are done on post-menopausal women. Do you see any differences between, we have a lot of early menopause because of surgical menopause or, others. Do you see any difference between older women who is post-menopause or younger women who is post-menopause? Is there any differences on your treatment outcome?
Well, I mean, if you take a younger woman who's put on GnRH agonist and also aromatase inhibitor, so they're medically induced menopause. There was some good data from Austria with giving the zoledronic acid every 6 months that they will get a little adjuvant effect even in that setting. But premenopausal in general, right? There's no benefit. But I think perimenopausal, even Monica, I think in the Azure study, there was no benefit even if you were perimenopausal adjuvant benefit, right?
Right. So, a young truly postmenopausal patient then would derive, I would imagine, the same amount of benefit as an older postmenopausal patient. But the Oxford meta-analysis actually did not show a benefit for premenopausal patients for bisphosphonates as adjuvant agent. It kind of actually, believe it or not, did show a sort of a detrimental effect. So quite the contrary. We don't know why. We don't know whether it was a statistical glitch or something, but it did show some sort of detrimental effect for premenopausal women.
Yeah, so
the older cancer survivor, I do run into the same difficulties, having a lot of information about these agents and reluctance to start the medications. And they do worry a lot about the side effects. A couple of interesting things, though, that some of these patients are, profoundly vitamin D deficient. And some of them have had, and vitamin D deficiency is a very big part of their bone health. Hold on one second.
Yeah.
And then the other challenge that we have is sometimes they've had additional radiation, which has already affected their bone health, and maybe also an additive factor in addition to the AI therapy that they may have had. They may have had skeletal metastasis and localized radiation kind of affecting the bone integrity as well. So there's additional challenges that come with patients who've had radiation as well for bony metastasis, and also a lot of vitamin D deficiency. And as you mentioned, a lot of information about these medications on the internet that they're already scared about them. So a lot of times I have to refer them to endocrinology for a longer discussion.
Yeah.
Are discussed, and I utilize avidly our bone health clinic at Mayo Clinic to convince sometimes that, and a lot of them think that because they're 80 or 81 that they won't have enough time to get benefit of these medications. And these are patients in remission, and I have to tell them that within 6 months to a year the benefits start to come. So unless there's a very big reason not to take therapy, we should try to find an agent that's suitable for you. So there's many interesting, like you mentioned, date information out there, because of which we have to go through a lot of bias removal and getting proper help as well. Sometimes, we have to seek help with endocrinologists or to talk to the patient about options. So, well, thank you for a wonderful presentation. I just wanted to make that point with seniors, with the older people above 85, a whole different paradigm of challenges. They have more medications. They also experience a little bit more side effects. Sometimes they may have reduced kidney function. So they do present a unique group of individuals with more, sort of side effects and complications sometimes, or fear of complications from these medications. So
Yep.
they do really well, though. Some of them do, of course, run into difficulties, but most of them do really well.
And conversely, I think, thanks for that. And conversely, we would refer to you guys, geriatricians and so forth, to maybe reduce fall risk, maybe reduce polypharmacy if we can, that kind of thing. for sort of weight loss and frailty issues and whatnot.
Sarcopenia and so forth.
Yeah, and their exercise regimens, you know, we also take the help of cancer rehabilitation specialists because their exercise regimens are, which is a very big part of bone health in these patients, are often not very tailored to what they should be doing. It's kind of a little bit disjointed sometimes. Their warm-up sessions or how much aerobic activity they're getting, how much weight bearing they're getting. So I think a very important partner for us in bone health with endocrinologists is also the cancer rehabilitation specialist, who eventually give them a long-term exercise regimen, you know, that helps the medications do a better job.
Yeah, I send a lot of people to PT, to physical therapy too, if I can.
Yeah. Okay, so why don't we switch now to our key takeaways? Can we show the slide? Okay, anybody wants to venture on what do you think are the key takeaways from today's lecture?
Don't be shy and just anything you want, actually. Anybody want to
Yes.
ask a different question or whatever?
A very elementary question.
Yeah, sure.
Yeah, not at all. Yeah.
So for our young women who either underwent oophorectomy for prevention of ovarian cancer versus or young women who had breast cancer in their 30s, let's say, and so they get chemo and then, you know, it is all blown out and then period never comes back. When it is the best time to start to evaluate the bone density, and how often we should repeat it for younger people?
Well, I think if people, for example, are being sent into menopause either by chemotherapy or you do even an oophorectomy, risk-reducing oophorectomy, let's say that, you know, they have genetic history or something, then I would like a bone density as a baseline.
Yeah, I agree immediately.
I mean, not you know, within a few months. I mean, within like not within 10 months, within like a couple of months from when they've done their oophorectomy, so that you have a baseline. And then if you start them on an AI, that's of course an additional insult. And then there is actually a graph, a slide that I have showing that the largest amount of bone density loss actually does happen in premenopausal women that are being put into menopause artificially, either by chemotherapy or by ovarian ablation. And then on top of it, of course, you put the AI. So that's really kind of a massive hit towards bone density. So then if you start an AI, you could repeat the bone density test a year later. You know, sometimes there's issues with insurance approval because it's technically every 2 years. But sometimes if you can write a letter or say that, you know, patient is young and she just, you know, did a oophorectomy and she's on an AI, she's at high risk. So you could technically repeat it 1 year later rather than 2 years. But other than that, you know, just start the bone modifying agent in this kind of patient because she's going to lose a lot of bone mass.
Right, and that first 5 years after that menopause, you know, there's a large amount of bone loss that can occur. So if somebody's, you know, bone density is already low, it kind of makes sense to me to block that bone loss and prevent them from sliding into osteoporosis.
And even remember that adjuvant chemotherapy in itself, this is older data, even just adjuvant chemotherapy causes bone loss, even without anything else.
So with adjuvant, perhaps we should repeat it every 2 years without AI?
In general, bone density is discovered every 2 years, yes.
Yeah, and I mean, you know, once you're outside of that window of 5 to 8 years after menopause, and the patients, you know, in their 40s, they're not going to lose rapid bone loss. So if they're good, you know, you could stretch that out to much longer than that, 5 years or what have you, right, Julie? You agree?
Completely agree.
Thank you.
Thank you. Okay, so if we want to switch to the final slide, unless anybody has any additional comments. So just some announcement to all, if you can please complete the session 5 survey, and then if you can invite also all your multidisciplinary cancer care team and medical neighborhood partners to future meetings, and consider care coordination and implementation of quality improvement. And also you can all sign up for a patient case presentation, and the next meeting will be Friday, October 30th. So right before Halloween, I guess.
We're gonna come in costume.
Yeah, that would be a good idea, actually. I think we should. 4 to 5 p.m. for
Skeletons.
session.
Everybody has to be a skeleton.
Yes, for session number. That's another good point. The good is everybody's dressed as a skeleton, a healthy skeleton.
Group picture.
For section 6, and this will be on prostate cancer, management of bone health issues in prostate cancer. And I think this is our last slide, and I thank you everybody for the attention. And if anybody has any further comment, feel free, and otherwise we'll regroup in 1 month.
Thanks, everyone. Dr. Faruqi, Dr. Fornier, if you could just stay on.
Yeah.
Sure.
That would be great.
Thank you.
Have a great weekend, everyone.
Thank you.
Bye.
Thanks.
Okay, it looks like we've got a couple people still in the room. Give them a second to hang up, and then we can debrief.
Okay.
Got a 305 number.
I don't know who that 305 is. It was a little bit difficult to do the introduction because.
Isn't that Florida?
Yeah, 305 is Miami.
Yeah, it might have been one of our staff who we invited last second, so she might even be on another call trying to join this call at the same time. But it's okay, we can go ahead. So how did you think it went today?
Good. Sorry, I couldn't get the. I think that's me. I'm a bad not a tech savvy person, so I don't know why I wasn't able to advance the slides.
No worries at all. We had it covered. That's my job on this end, to help out when we're having those issues. So no, it was fine for me. I'm sorry if I wasn't moving quick enough. I was trying to.
No, it was good.
Follow all your amazing animation.
No, I think it went fine. I apologize if I didn't see 2 people, but I was looking at the participant list and it kept moving up and down. So I wasn't sure who I had invited already. I think they joined late, and the name, the names are very wild. So I didn't want them to invite them twice.
Oh, no worries. No worries.
That would have been very embarrassing. I mean, what do you mean? We just introduced ourselves.
Oh, no, it's definitely, and this is part of the ECHO model too, is that if people are missed in the beginning, it's okay to go back and grab them in, because you really want everyone to feel like they're like part of this community of practice.
No, definitely. But because the list kept moving up and down, and I didn't know who I had called upon. I couldn't remember if I called upon them already or not, and I didn't want to call upon them twice. They're like, what are you talking about? We just introduced ourselves.
No worries. No, I think it was good. I think everyone got a chance to speak, so it was good.
It was good, yeah.
But yeah, thank you so much, Dr. Faruqi, for your presentation. I think everyone really appreciated all the studies for sure.
Oh, great.
And the back and forth between both of you as well.
Yeah, Monica and I are old friends and colleagues, so we have a good working relationship. So we should,
We should do another one. So one breast, one prostate, one breast, one prostate.
For sure. Well, we've got some coming up, and for sure we invite you, Dr. Fornier, to go out and sign up for presentations if you have availability now.
That's fine.
And Dr. Faruqi, as always.
When would it be?
It's on our MS Teams site. It's like a central repository. I can send you the link.
Yeah.
Make sure
but when? Which date would it be?
You get to pick based on your availability and your interest and expertise.
Okay, so I think I can do the next one in breast.
Okay, awesome. Well, again,
that would be, I guess, at the end of November then?
It's usually the last Friday in the month, but November we're doing it earlier in the month, and December we're doing it earlier in the month.
Because of Thanksgiving.
Yeah.
I can do that. That would be like November 21 or something, yeah.
for sure.
I can do
I'll
that.
send you the link to the schedule so you can take a look at it.
Perfect. No, I think I had it on Teams, but yeah.
But I was really happy to see like everyone, I feel like everyone, there were a few people who didn't speak, but there were a lot of people who spoke.
Yeah, there
I
were a
think
lot of people who spoke.
Yeah.
We'll continue to try to work on those patient case presentations, getting those.
Yeah, we want them to give us cases, and yeah. I mean, you would think, because you say,
It
well,
would be nice if people came with a case to present in advance.
right, and you know, I think the key thing to reassure them is that it doesn't have to be so minutely detailed. Like, you know, just give us the gist of it and
Some
what
bullet
the,
points,
you know,
yeah.
what the dilemma is.
Gotcha.
It's just, you know, very informal, and you know, what question, you know, do you need help answering on this case, you know?
Yeah, we have a case presentation template, but it is more detailed. I could probably break it out into like a slide and make those bullet points, and like you said, pose what your problem is, what your issue is that you're looking for mentoring or feedback on. That might be a little less intimidating. But yeah, I was stalking people for a while and then I backed off. So I think it's okay for me to reconvene that again.
Right.
Get people to, but I think they're also more comfortable with the format, and everyone's schedules, everyone's adjusting to this new normal a little bit too. So I think that will help.
Yeah.
But yeah, appreciate both of your contributions today. Thank you so very much.
You're more than welcome.
Thank you for arranging.
Sure, and have a great weekend.
Thank you. You too. Have a great
Bye,
week.
everybody.
Bye, Aziz.
Bye, everyone.
Ciao, ciao.
Bye. Ciao. Ciao.